Hello, everyone. Welcome to the RapidAI Lunch Symposium on AI-driven radiology advancements. My name is Dan Knickerboker. I'm the head of product and clinical marketing at RapidAI. Today, we're going to have a collaborative presentation between myself and Dr. Yedavalli. Dr. Yedavalli is the author of over 140 publications and has received numerous awards for his research in neurological imaging. He's the associate professor of radiology in the Division of Neuroradiology and the director of stroke, neurovascular, and perfusion imaging at Johns Hopkins University. He's also the chief of neuroradiology at Johns Hopkins Bayview Medical Center. Dr. Yedavalli, it's a pleasure to share the stage with you.
Thank you, Dan, for that kind introduction, and welcome everyone. Just as we get started, I want to just see a show of hands for how many people have felt an increase in their caseload over the last couple of years in their practice. Yeah, as we see, the vast majority of people within the audience have felt this burden of the increased radiology demand that we see. And this has led to a substantial issue with understaffing within the majority of our departments. 69% of the radiology departments within the country are currently understaffed. And this has led to significant burnout amongst our radiologists, especially with the more misses that we have, clinically significant misses that we have, because we need to keep reading cases faster and faster in order to maintain our turnaround times. So as of right now, about 60% of practices use some form of clinical AI. But not all AI is created equal, right? There have been a number of studies that have shown mixed results with different AI platforms. This is one example here of a study that used an intracerebral hemorrhage platform based on non-contrast CT examinations, where they found that the mean turnaround times were not significantly different after using the AI platform. This was another example of a study that was performed that also used a hemorrhage detection platform on non-contrast CT, where they found that there were more false negatives and false positives, which led to even more issues in terms of turnaround times and more unnecessary imaging for these patients. But there's also a study that was recently performed that for chest CT interpretation times, which actually found that the AI platform that they used did significantly improve their turnaround time. So overall, it's been a mixed bag, and not all AI is created equal. So because of that, there have been a number of radiology societies across the world that have created a joint statement on how we use AI in our clinical practice. And most of the focus has been on accuracy, improving detection, and minimizing our false positive, false negatives, which can, of course, lead to dire consequences for our patients and our patient care in general. And also how we can incorporate AI platforms into our everyday decision-making process when we're treating these patients. Hand it off to Dan.
Yeah, so with that, I'd like to introduce the RapidAI Enterprise Platform. This is a system that's designed to provide deep clinical AI and seamless integration. So what do I mean by deep clinical AI? This is a solution that's designed to provide real clinical utility to improve the accuracy and efficiency of the entire care team. Not only is it going to provide you with triage, but allowing you to also localize, quantify, and track the changes across the imaging. And when we talk about seamless integration, it's going to work within the systems that you already have in place today. A couple of examples are within your current PACS system, you're going to be able to have the AI outputs directly into your system, as well as worklist prioritization and reporting integration. We're going to talk about a little bit more of these in a bit more detail. But the first most important thing, as Dr. Yedavalli mentioned, in terms of the assessment of whether an AI solution is useful, is first and foremost the accuracy. And I can tell you that the accuracy of Rapid is unmatched across the solutions that we play in. In a head-to-head pooled comparison of a other competitor, RapidAI's sensitivity and specificity is consistently higher across the board. And in many cases, it's the only solution available. And this is true across stroke, hemorrhage, and aneurysm solutions. Now, this is validated in over 400 publications around the world, 11 of which are in the New England Journal of Medicine. Rapid was the core technology in some of the pivotal stroke trials that helped to change the guidelines, including Dawn and Diffuse 3. And that's probably one of the reasons why Rapid is available in over 220 hospitals today. We talk about some of the impact, Dr. Yedavalli.
So at Hopkins, we employed Rapid in 2019 and saw substantial positive impact because of the platform, especially in terms of door-to-needle times, for instance, when we're able to get our patients who were diagnosed with some sort of vessel occlusion, thrombolysis in a more timely manner. And that's just one of the main instances where the implementation of Rapid has substantially impacted our practice in a positive way.
And this is all powered by the Rapid Edge Cloud. The Rapid Edge Cloud is a hybrid platform which allows you to implement the solution either on premises or over the cloud or a hybrid of the two. Now, this is important in terms of providing flexibility as well as redundancy for your solutions. If for whatever reason one of the systems goes offline, you have the ability to continue to provide care for your system and for your patients. There's one relatively high-profile scenario where an IDN had a security breach and needed to cut off all internet access across its health system. Because they had implemented the Rapid hybrid solution, they were able to continue to diagnose strokes and manage those stroke patients, even though they weren't able to access their EHR. And so they continued to provide patient care in the most urgent settings over the 3-day period that they were out. Not only does it provide the security aspect, but the hybrid solution actually allows you for faster processing and faster results through the parallel processing. And the Edge Cloud allows for third-party integrations. We have many solutions across the Rapid system, including within stroke, trauma, aneurysm, and PE, but also able to integrate into major third-party integrations, whether they're commercially available or they're homegrown within your hospital systems. So now it's the fun part. Let's talk a little bit more about how you can use some of these technologies. The first one I want to go into is the collaboration and communication tool. In this scenario, you can see that the radiology team is able to communicate with the entire care team right from their workstation. So you're able to see across mobile users as well as the radiology team all the imaging at the same time, communicate, and you can actually review the images in parallel at the same time. And so here's that example.
And this is particularly unique in many instances because based on the hospital system, there can be a varying degree of communication between neuroradiologists and our stroke neurologists and neurointerventionalists, for example, too. So this type of platform allows us to real-time collaborate in a more multidisciplinary approach, which ultimately improves the patient care by being able to review the imaging and even hand it off, which is one of the main features of this. We can hand it off, for example, to the neurointerventionalist who may be using the CTA or MRA for their treatment planning in order to thrombectomize the vessel occlusion.
Great. And the next aspect we want to talk about is worklist prioritization. The Rapid system will integrate with any of your PACS systems to help to prioritize those cases that need the most urgent reviews. So it can highlight both any of those cases that are reviewed as stat or any that identify positive findings. And so in this particular instance, it's highlighting a suspected aneurysm case.
But this is particularly useful for us as radiologists because this is one of the main issues that we encounter from a logistical and workflow perspective. One example I can give, at least at Hopkins, is we cannot triage every single outpatient study that's performed. And there are many instances where these studies are left over the weekends. Some of them may have acute findings, but how do we get around that? A platform like this that's able to screen these cases and be able to bring those cases that have suspected acute findings up to the top of the work list such that the on-call radiologist reads them is hugely beneficial from a patient care standpoint, but also medical legally.
So if you kind of take to the next step, we mentioned the AI outputs directly in your PACS. And so this is an example of what that looks like. If we were to click now onto that particular aneurysm patient, you can see the outputs directly in the PACS. So in this case, right, you see this is an aneurysm patient. You're able to manipulate the 3D output. As you look to the aneurysm specifically, you can highlight that particular aneurysm, and you're able to obviously review that, but also look at the measurements that come with that case. And if this happened to be a case where there was a prior and you're now looking at the follow-up and you wanted to compare the two, you're able to look at the measurements there, but you're also able to look at both aneurysms side by side and actually even overlay them so you can see what the morphology changes are. And so the last attribute that I want to focus on here in terms of driving efficiency is eliminating those repetitive tasks that really slow you down in terms of improving your reporting and turnaround time. The first of which is report integration, then automated 3D reconstructions, as well as AI measurements. So when we talk about the report integration, anything that's collected within the Rapid system from that scan, including patient info, the scan details, the suspected findings, can automatically be pre-populated into your report, including the measurements that are collected from the AI.
I think this is a particularly unique feature of this platform that has significant implications for our general workflow. Because as everyone who's in the room, when they're practicing radiology, one of the most tedious, time-consuming tasks is putting in those measurements, whether it's an aneurysm, a lung nodule, anything across the body. The measurements take a significant amount of time, and there may be a lot of variability between who read it previously and yourself with how those may be measured, for instance, too. So this also allows for more quantification and standardization that's inputted within our report. So for instance, an example like this could be integrated within PowerScribe, which is, we use PowerScribe 360 at Hopkins, and that's one of the more commonly used dictation systems, but it can work with a number of different dictation systems such that these measurements get automatically integrated into the report and inclusive of prior studies, which there may be interval changes between these abnormalities, which are also included in the report.
So give you a chance, give you a sense of what that looks like here. Here's an example of our aneurysm solution, not only providing the linear measurements across multiple different thresholds, but also volume and area. And you can see the morphology differences there as well. And when it comes to hemorrhage, you're also able to measure the total volume of that hemorrhage across multiple different measurement types.
And this is especially useful not just for aneurysms and intracerebral hemorrhage cases, but for a number of instances where we have to put in all of these measurements in a timely fashion and turn these around. And this is a perfect example of where we can assess subtle changes that may be difficult sometimes to assess just from qualitative assessment. And it also helps us have more standardization with quantification for future follow-up studies. In fact, this was an example with the Rapid Intracerebral Hemorrhage ICH platform that was performed in a cohort of 127 patients where the measurements were compared to expert neuroradiologists as a reference standard, and we can see that there was a near perfect correlation between the platform and the expert neuroradiologists. Plus, there were some studies that were done that showed the ICH module helped save a considerable amount of time per case, up to 10 minutes per case, just by incorporating these measurements. And lastly, I think this is a very important point. ICH volume is one of the main parts of accreditation by the Joint Commission for stroke centers in general. And this group out of Nebraska found that after implementation of their ICA of the ICH platform, they were able to increase compliance of ICH volume calculations from 30% to nearly 100%. Now we're going to move on to to focus more a little bit on our aneurysm platform. And as we all know, aneurysms are one of the most challenging pathologies that we can find and are particularly difficult to detect and assess, especially in those cases where we find them incidentally when we're looking for something else. And in fact, some prior studies have shown that aneurysms are missed in up to 15% of cases. And as we were talking about before, the inconsistencies and the differences in measurements between clinicians can cause major issues in terms of assessing whether aneurysms of different morphologies are truly growing. And with that can lead to significant differences in risk of rupture and increase the risk of rupture considerably if these aneurysms are growing, which we see in about 5% of cases. And this is a great example of how we used the Rapid Aneurysm platform in a particularly difficult case. This was a patient who had a poor quality MRA and ended up actually having a small PCOM aneurysm that was off of a fetal PCA that was not detected initially. A year later, the patient's aneurysm ruptured, and unfortunately the patient passed away, which ended up leading to a major lawsuit. This initial study, this suboptimal study, was run through our ICH platform, where the aneurysm platform was able to detect that initial aneurysm. So this is a good example of where having this type of detection and quantification system can be particularly useful and can significantly impact patient care in the future. This is another great example that we have here. This is an example of an aneurysm coming off of the supraclinoid ICA that was initially missed. And after using the aneurysm platform, this was detected, and this patient was able to get to intervention and was eventually pipelined for that aneurysm, which could potentially save them from future rupture, as we saw in the previous case. We got one last case for you guys. So here we have an example of a patient who has some MRA images. In 2017, this patient was found to have a laterally directed aneurysm that was between the PCA and SCA on the left. The patient was unfortunately lost to follow-up, but then subsequently came back to the hospital, admitted for a DVT, so incidentally, but did end up getting routine MRA brain imaging, where the aneurysm was again seen and was read as no change initially. But we can see after using the aneurysm platform with the different degrees of quantification, not just volume but also surface area, we were able to see that that this aneurysm in fact doubled in volume over these last 7 years. And here's the overlay to again highlight and emphasize the difference in volume between both of the aneurysms. So this is a great example of where having that quantification with the aneurysm platform can significantly impact patient care, especially in terms of risk of rupture, as this patient's risk of rupture grew exponentially with the volume doubling. Now we're going to move on to our stroke platform.
I want to give you a little bit of a high-level overview of the stroke solution. We talk about deep clinical AI. This is a great example of that. When you talk about a system of care where not every hospital within your system is going to have the access to CTA or CT perfusion, let alone the expertise to review those images, you want to make sure that you're still capturing all of those patients that are at risk. And so this is a great example here where starting all the way in the left, our non-contrast solutions are able to triage for hemorrhage, as well as identify strokes on non-contrast CT, as well as give you AI aspect scores. As you move further to focusing on whether or not this patient should be transferred, our CTA modules are able to support detection of LVOs as well as MEVOs. And we've spoken about the rapid workflow optimization. And as you work your way into the main hubs and you want to get to more advanced imaging, of course, we have CT perfusion, which Rapid was founded on to allow for much more detailed assessment of those patients, as well as 3D reconstructions to aid in the visualization and treatment planning there.
Now to focus a little bit on the non-contrast CT stroke platform that Rapid has. This is, of course, especially useful for detecting early ischemic changes, but particularly with large vessel occlusions based on the hyperdense vessel sign, which we can see, of course, with ICA occlusions and M1 MCA segment occlusions on non-contrast CT, as we see in this example right here of a left M1 occlusion with the hyperdense vessel sign. So this is particularly useful for triage, and this is important, particularly in respect to equity of care, because we have a lot of smaller hospitals across the world that may not have perfusion capabilities, CTA capabilities, even for that matter too. And having a platform like this, which can detect LVOs, especially when we're seeing more patients, for instance, in the rural United States, there's still a significant burden of stroke patients who live hours away from any comprehensive stroke center, but may have a local hospital that has some limited capabilities. Having a platform like this allows for earlier detection of the vessel occlusion, such that those patients get to a comprehensive stroke center and get the treatment that they need in a timely manner. This is actually a study that we did last year evaluating the rapid non-contrast CT stroke platform, where we compared the performance of the platform for large vessel occlusion and ICH detection to general radiologists as well as neuroradiologists. And we actually found that the platform was superior to both a combination of general and neuroradiologists for both LVO and ICH detection. Another part of the stroke platform that's an important component is the rapid aspects component of the entire platform, which is particularly useful for improving our inter-reader variability. For those who may be using aspects in their practice and reporting it, we know that aspects has a relatively poor intra and inter-reader variability in general. And this is one area where having the aspects platform can help considerably with improving that. And there's a prior study that was done comparing it to expert neuroradiologists as a reference standard that showed very strong agreement between the Rapid Aspects platform and the neuroradiologist reads. Additionally, this platform also helps general radiologist performance. So in prior studies, general radiologists who implemented this specific platform were able to get to the level of a neuroradiologist within their clinical practice. And not only that, lastly, the Rapid Aspects platform is especially useful within the early time window. You know, it's extremely difficult to assess for early ischemic changes, especially within the first couple hours. And this is where having the Rapid Aspects can help detect some of those subtle changes we may see in patients who have acute ischemic strokes. Another area of advancement that's ongoing and that's a growing area of interest is medium vessel and distal vessel occlusions. In fact, 25 to 40% of patients who have acute ischemic stroke actually have a medium or distal vessel occlusion. And that can cause very disabling symptoms for these patients and affect their quality of life. So it's very important to be able to detect these and characterize these lesions. And with the use of the comprehensive rapid platform with the LVO, the vessel density, and the CT perfusion components within it, we're able to detect medium vessel occlusions in over 90% of cases. And just for reference, without perfusion, just on CTA alone, the sensitivity for our detection, even as experienced radiologists, is around 33%. So this significantly improves the performance of being able to detect these lesions across the board. Another area that's particularly important and relevant to our everyday practice is being able to detect stroke mimics. We see this often in our practice. So with the perfusion component of the software, we're not only able to rule out ischemic stroke, but also rule in specific stroke mimics that are relatively common, such as seizures or tumors, and that can very much impact care for those patients and get them the treatment that they need or the referrals that they need faster. Another area where the CT perfusion platform in particular is helpful is not only detection, but also prognostication. And a lot of the focus has been on LVOs where it's been validated, and of course, a number of randomized controlled trials and additional larger scale studies. But we've also found that it's been useful for medium vessel occlusions as well, especially with the focus being on collateral status measures or quantitative collateral status measures that the rapid CT perfusion platform is able to generate. So this is the hypoperfusion intensity ratio, which has been shown to be a surrogate of collateral status in these patients. And we all know that collateral status can significantly improve outcomes if they are robust for patients, not only with LVOs, but also with DMVOs, based on the publications that we've had here, looking at the hyperperfusion intensity ratio and the cerebral blood volume index, both of which are indirect surrogates of collateral status. And patients who have lower HIRs, so it generally goes from 0 to 1, the lower the HIR, the more robust the collaterals, because it's a ratio of the Tmax greater than 10 seconds volume to the Tmax greater than 6 seconds volume. So the lower the better there. And then with the cerebral blood volume index, this is a little bit different than the HIR, because it's able to detect a compensatory response by maintaining the blood volume within the area that's hypoperfused because of the vessel occlusion. So the higher the better in those instances. And we in fact found that based on our studies, that these cutoffs differed from LVOs. But again, this highlights the importance of and the utility of the CT perfusion platform for prognostic purposes as well. Not just for functional outcomes, but also safety outcomes. As we all know, one of the most dire complications that we have within stroke, even amongst those who are treated with endovascular thrombectomy, is hemorrhagic transformation, which can of course lead to poor outcomes in general. Here we also found that the cerebral blood volume index, lower CBV index, was associated with a higher likelihood of hemorrhagic transformation in medium vessel occlusion patients, which was also already validated in many instances for the LVO population, but we've also seen that that's the case for the medium vessel population as well. So now we're going to move on to some of the new exciting developments that we have.
Yeah, so we're happy to tell you guys about some of the brand new solutions that are available on RapidAI today. The first of which is our Rapid 3D solution. Now, this is automated 3D reconstructions as well as CPRs right on your PACS, right available as soon as the system analyzes it. So no longer having to have your techs analyzing this or sending this out to a third party. You're able to get this right in time with the rest of your scans. Dr. Yedavalli, what does this mean to you in terms of improvement in time and efficiency?
Yeah, this can really impact how we look at these patients, especially from a treatment planning perspective. Our endovascular neurosurgeons and neurointerventional radiologists like to have their CTAs for treatment planning in those patients who have a vessel occlusion, to assess the degree of tortuosity or the degree of stenosis. So having this type of solution can be especially useful in that setting.
And then we spoke about the Rapid platform being able to provide you with integration with third party. There's some brand new integrations that we're able to bring to you today, including incidental PE, cervical spine fracture detection, as well as vertebral compression fracture detection. And these are just the beginning to demonstrate to you the capabilities of bringing in and building out an entire solution.
So as we've shown today, the Rapid platform gives us a lot of capabilities that can help boost our efficiency in general in our general radiologic practice by eliminating a lot of tedious tasks. For example, measurements of aneurysms, intracerebral hemorrhage, for instance, that can also help standardize for follow-up imaging. And we've also shown the case with Worklist Prioritization, which is of course a major logistical and workflow challenge that we all experience in different practice settings. And being able to use this platform to prioritize the work list such that those cases that do have acute findings come up to the top of the list really improves our turnaround times, especially for detection and characterization of a lot of these acute findings. Oh, I'm sorry.
And when it comes to integrations, right, as we talked about the worklist prioritization integrations, the reporting integrations, and that's all powered by the edge cloud, as we talked about, the hybrid between on-premises and cloud, giving you that faster access and that redundancy and security that you're looking for, as well as third-party integrations with other solutions.
And finally, one of the main reasons we're here today is the promise of implementing an AI product like this within our everyday practice. And this specific platform, our Rapid Enterprise platform, has been shown to be highly accurate in a number of different settings, not just for large vessel occlusions, but also for medium vessel occlusions, aneurysms, intracerebral hemorrhage. And it can help in a number of instances, as we touched on with some of the examples we showed, for triage, characterization of a lot of these lesions that we find, and more accurate quantification, especially for follow-up imaging. And lastly, it's also useful for being able to show those interval changes, which can be subtle in many instances, especially, for example, with the volume measurement case that we saw with the aneurysm that changed significantly over the course of those 7 years. So being able to detect those types of changes with different types of measurements, both surface area and volume, and more quantification, that can help with improving the quality of our reports and improving the turnaround times.
Thank you so much, Dr. Yedavalli. It's been a pleasure. We're going to open up the floor to some questions. So if anyone has any questions that they'd like to bring to Dr. Yedavalli, there's a microphone right here in the center of the room. Dr. Yedavalli, I'll set you up with a little bit of a layup question, if you will, right? What has been one of the biggest impacts that AI has brought to your hospital system?
Yeah, I think one of the main things that we've found was that after implementing Rapid in 2019, that we saw a significant increase in the number of patients who were eligible for mechanical thrombectomy. And this of course has major implications, because we're able to provide a life-saving intervention for these patients by being able to more appropriately triage them and see who are eligible. And that of course translates to better functional outcomes for these patients.
Thank you.
Hi. I just have a question regarding the aneurysm product. What's the typical turnaround time on receiving the measurements and the identification of the aneurysm? How long does it take to get sent to PACS?
Yeah, so it's really going to be system dependent, and as we mentioned, it depends on what whether you're on the hybrid, whether you're cloud, or you're on premises. The detections are going to be within a matter of minutes for the triage system.
And then the measurements, that'll take additional time?
Those will take a couple more minutes as well, yeah. But again, it's dependent on how much data you're pushing through the system.
Thank you.
And I think one important point, thank you for your question on the aneurysm platform. One important point is that it can also detect multiple aneurysms as well, and assess the changes for follow-up imaging. So it's not just a single aneurysm or single abnormality detection.
I have a question about, I saw the list of the studies, and some of them were 10 years old. Is that really just, you had it in there, or because the data seems to be a little bit 10 years or a few years older than what it is now with the new technology? Have you been able to?
With the specific
Yes.
The specific studies that we were
when
showing?
you said the studies, they were all like 2013, 2014. I'm just curious if you have used the new technology with the new scanners.
We have. We wanted to show those specific studies because those were some of the seminal studies that showed the benefit of the product initially. So that's why we highlighted those, even though they're a little bit older. But we have.
Yeah. What about a false positive? Do you have any report on false positives that were identified and not found out to be correct?
Well, we found that with the platform, the number of false positives have decreased. Of course, they're not going to go away entirely, but they have decreased, especially for aneurysms in particular. So that has significantly impacted our practice and increased confidence, especially for our neurointerventionalists with our reads.
Yeah, and some of the improvements, as you mentioned, is recent improvements is case rejection in terms of if the scan was not well done, rather than assessing it and trying to detect what's going on. It's going to reject that, and that's going to reduce some of the alerts and the false positives that you may have encountered in maybe the initial launch.
How was the performance of the software on blister aneurysms?
You say that one more time?
Yeah, on blister aneurysms.
Blister aneurysms?
We haven't done a study that's specific to blister aneurysms yet, because they're naturally very, very difficult to find to begin with. But I would suspect, at least from the way it's able to detect some of these smaller aneurysms, that it would improve our accuracy, which is probably relatively low right now.
All right, well, this concludes the session. Thank you very much. Please visit us at our booth at booth number 5555. Thank you so much.